elevated for what's going to happen when they get to stage 5 and need, they're going to need some type of renal replacement therapy, okay? So you're going to need something that's going to replace their kidney function. And that's going to be either in the form of hemodialysis or peritoneal dialysis or kidney transplant, okay? So what we don't want to see is a patient shoved in the ED with massive uremic symptoms and on death's door needing immediate dialysis. Anytime there's a situation, the risks are going to be much greater. And then stage 5 is typically, and this is really considered the end stage, so the ESRD. It's severely impaired excretory, regulatory, and hormonal renal function and balance. So the kidneys are not producing urine. They have considerably elevated BUN and creatinine, elevated phosphate, hyperkalemia, fluid overload, and very low urine output, so they are polyuria. So without intervention, these patients will die. So we talked about the 2 most common causes of chronic kidney disease. Diabetes, they call it diabetic nephropathy, right? So patients who have effects of the side effects or the insult of just elevated sugar is toxic up to the kidneys. So patients with uncontrolled glucose levels are going to be at risk for diabetic nephropathy. So we're talking uncontrolled with both of these. So there's so many patients that maintain normal sugars, and they do fine. They never get to this point, right? It's the same with hypertension. Keep your blood pressure in control, decrease vessel damage. You're going to see patients that end up, not having renal disease. Now, some patients have both diabetes and hypertension. I'm sure you've seen that with your patients. So that's obviously a double whammy, and those patients are going to progress and be at higher risk for chronic renal failure. Another common cause of kidney disease, chronic kidney disease, is polycystic kidney disorder or disease. Anybody know a patient or take care of a patient with polycystic kidney disease? So what you'll notice is the kidneys just have a massive amount of cystic tissue, and it affects the kidney function. So these patients need a transplant. Okay, putting them on dialysis is not going to help the function. So they need a kidney transplant. So these kidneys, when they do remove them, can weigh as much as 50 pounds. Just from the number of cysts on them. Another common cause, or actually not as common, so those are the most common. Less common is glomerulonephritis, and that can be as a result of infection or autoimmune disease, or infection that precipitates autoimmune disease, such as a strep infection, is commonly associated with glomerulonephritis, and that, whether it's an exam question or not, that's something important to know.
With the polycystic kidney disease, would you see like younger individuals on dialysis? Like, is it something that's diagnosed like early on, or?
So polycystic kidney disease, them. Polycystic can be hereditary. Glomerulonephritis is autoimmune, can be hereditary. So this just kind of breaks down different percentages for the things, so you notice, what is fairly rare. Another autoimmune disorder that is rare for nephropathy is systemic lupus erythematosus, sickle cell anemia, nephritis, drugs and other toxins. So if you speak to people working in a dialysis center, the majority of the patients we're going to see are those with the uncontrolled diabetes and hypertension. And then all of those other things are like things that affect perfusion. They have that acute insult, and then it leads to chronic kidney disease. These are all of the medications that are associated with potential for acute renal failure. Okay, so that's just important to be aware of. There are quite a few. So when you're taking care of these patients and you're giving some of these medications, you see some other things like cocaine up here as well. When you're administering these medications, what's important to do in terms of teaching? Like, how can we help these medications pass through the body to get absorbed and hydration, right? So when we bring all our medicines in to our patient, we've got that little 3-ounce cup of water that we bring in with our meds. If you're given any of those other medications, you want to make sure you have a nice full cup of water, unless they're on, some type of fluid restriction, right? Maybe they're in heart failure or something, and there's those limitations in the amount of fluid. But otherwise, encourage these patients to drink lots of water. And keep water at the bedside if there's no restriction. Okay? If they've had some type of dye, right? They've gone to MRI, they've gone to CAT scan, and they've had a CAT scan, CT with contrast, right? If there's fluid orders, IV, you're making sure they get all of those fluids. You're bringing in lots of water to help flush that from their system and through the kidneys. Because if they're getting a lot of dyes, we watch that creatinine level, right? And we make sure that we're not putting them in a state of kidney disorders. So we're watching that creatinine level. So just something very, very simple is encouraging your patients to drink. And as we get older, right, we don't think to drink water. So make sure we're keeping water at the bedside for them. Just to mention with causes with juvenile diabetes. So our patients who develop their type 1 diabetics and they are insulin dependent. Sometimes we see these patients, when they're under the care of their parent, they're living at home, they have people helping them regulate their blood sugars. Often when they become independent, they go out to live on their own, they go to college, we see an increased risk rate of noncompliance. And we see the hemoglobin A1C going up because the 3-month window represents that noncompliance that now you might see for them. So really, really important for type 1 diabetics, our juveniles, about 50% of them go on to develop chronic kidney disease and end up on dialysis. So that's a pretty high percent. So we want to really, if you're working with that population, really important to make sure they have all the resources they need to stay compliant. Often they'll bring these patients into a dialysis center, like, and say, this is what your life could be like if you don't keep that blood sugar in control, or if your blood pressure in control, or you continue to abuse drugs. you could end up on dialysis and seeing, what these patients go through. So the treatment goals are going to focus on slowing progression. They get to that stage 2, stage 3, keep them there through compliance. Support body function, hypertension, diabetes, all those things are important. Provide psychosocial support and then educate regarding the treatment options. So I mentioned uremic syndrome as being like how these patients end up in your ED. They present in uremic syndrome. This is like the end stages of kidney disease, right? They're at this point, and it affects every system in their body at this point. So we're going to see, and this is the result of just toxin buildup, urea nitrogen in the blood, and creatinine in the blood that at abnormal levels leads to all of these symptoms. So in terms of GI symptoms, these patients, they're going to complain of loss of appetite, nausea and vomiting. They can have a uremic smell to their breath. They're at risk for GI bleeding and peptic ulcers. As far as neurological problems, these patients, with their electrolytes being out of whack, their calcium levels. We talked about with hypercalcemia that can occur. These patients complain of muscle and joint aches. We see calcium because of the effects of calcitriol and the effects on vitamin D. We see elevated levels of calcium. And hypercalcemia can lead to, I mentioned in endocrine, we talked about parathyroid disease, like bones, thrones, and psychic wounds. So calcium is not going into the bone, it's in your vascular system causing atherosclerosis, right? Patients complain of joint pain. It can cause some psychiatric disturbances. Right? Abdominal pain. Okay? So all of these are those effects of hypercalcemia. So one of the things that we do for these patients is give something called a phosphorus binder. So you might see all you guys that were on MEGAR 5. Who remembers giving phosphorus binders to their patients? So when would you give those? With meals, right? So with meals and snacks. And the phosphorus binder, you take it with food. It needs to be in the stomach at the same time as food. And it's going to help bind the calcium to the medication. And it's going to use it up so it's less available to be absorbed into the bloodstream and be available for atherosclerotic buildup. So phosphorus binders are really important medication for our patients with chronic kidney disease. So you take them with food so they can work in the gut to absorb calcium, to bind to calcium so there's less available to be absorbed into the blood.
The only way to get rid of excess calcium?
So you can do other things, and this is going to be an oncological emergency as well. So I've learned a lot about hypercalcemia and clinical oncology as well. So there are other ways, like diuretics, right? So you could use a diuretic. Not only do you lose potassium in your urine, but you also use calcium. And there are some other medications that you can use as well. These patients often are depressed, anxious, they're still in some denial. Often they've been through stage 3, they have become symptomatic, and now they're in late stage 4, and they are depressed because now they're facing their morbidity. So these are all potentially all the systems. They complain of a itching to their skin because of phosphorus.
What's the uremic frost?
The uremic frost. So if you're not excreting urine, you can actually excrete urine through your skin, and it creates like this uremic frost, and that causes contributes to like the itching. But patients in renal failure, like you can like press on their skin, and they will excrete urine through their skin. Right.
Can you tell it's urine? Like, is it quite different from like weeping edema? Can you tell that it's urine? Like, is it obvious?
Yeah, I'm thinking back to my ICU days, and it's yeah. So with this anemia, let's talk a little bit more about this. They used to try to keep hemoglobin around 10 to 12 for these patients. Patients in chronic kidney disease, before the availability of Procrit and all of those erythropoietin stimulating meds, they would require transfusions with most of their dialysis. So they'd become very, very anemic. So they would try to keep that hemoglobin around 10 to 12. We know hemoglobin carries oxygen. It's going to affect our perfusion. If it's higher than 10 to 12, if it's like 13 or higher, they found that there was an increased risk of strokes for these patients. And there was a little bit of conflict with dialysis units all over the country, where these dialysis companies and nephrology offices, they would get paid, they would have like monetary incentives to give Procrit, right, to give these different medications. But they found that when it was higher, so these patients were getting, they were reimbursed as they gave more and more Procrit, right? So the patients had these nice high levels because they'd be giving, all this Procrit, but then they saw that the risk of stroke increased. So that stopped. Obviously, the Medicare no longer reimburses for Procrit individually. There's like a bundle that Medicare will reimburse for a bundle of different medications, and the Procrit would be part of that bundle. So it's interesting how different incentives from insurance companies affects our care, but it does because money talks, right? So we gotta make sure that our care is best for the patient, right? And watching outcomes, controlling symptoms, and focusing on those things that are going to help our patient live longer. So we want to maintain that hemoglobin around 10 to 12, and at higher levels, we have an increased risk of stroke. All right, so our parathyroid hormone, we talked about calcitriol, but parathyroid hormone also causes bone loss calcium. So when in endocrine, we talked about, how parathyroid, when our calcium level's low, parathyroid hormones kick out to help, increase calcium levels through calcitriol. Okay, so it uses calcitriol to help bring, calcium levels up. So these again are all symptoms of low calcium, okay? So these are things you might see in your patient. And we know that calcium is going to aid in clotting, is important for transmission of nerve impulses, muscle contraction, and bone formation, along with vitamin D. And the goal is to, maintain a normal level of about 8.4 to 9.5. And patients should be aware of things that are high in calcium, like dairy products, dark green leafy vegetables, plants, and sardines. For phosphorus levels, they'd like to maintain a phos level between 3.5 and 5.5. And phosphorus is also going to be important for bone function, transfer of energy, and neuromuscular function. And it's in a lot of the foods that we eat. So, in most foods, and a lot of it because of the preservatives that are in food. So we're going to take a break, 10-minute break, and then we're going to come back and we're going to talk about what we do when we have that patient present at that end of stage 4 with uremic symptoms, and what are the treatment options for them. Talk about dialysis, all the different places there. All right. See you, all right? And you're gonna continue with treatment options. So these patients have gotten to the point where they are just not producing. They're producing very little urine, and they are just holding on to all of the waste products, fluid. Their electrolytes are affected. They have all those uremic symptoms, and it's imperative for life-sustaining. Life-sustaining measure that's imperative, or the patient will not survive. So the labs represent stage 4 kidney disease, stage 5 kidney disease, and these patients now need some type of access. Okay? They need some type of treatment that is going to take the place of the kidneys. Okay? So we look at several different methods of replacing the kidneys. Okay, so we have what's called hemodialysis, and basically we are using something artificial, which is a machine, to act as the kidneys. Okay. There's another method where we use the body's own abdominal cavity to replace the kidneys, and then we use it as a semi-permeable membrane. Okay? We can transplant the kidney, or the patient can choose not to have any treatment. Okay, so perhaps they're ready to let go. Have enough with all of their treatments that they've had along the way, and they're ready for palliative care. So we have to support whatever their decisions are. Kidney transplant is an option. It might not be an option for everybody. Alright. So first, your patient comes in, and they're going from dialysis treatment to dialysis treatment. Everything that they've taken in has accumulated since their last dialysis treatment. So they are gonna present like, with like third stages, you're gonna be puffy around the eyes, around, in the body, in the neck. You're gonna see all the fluid from their last dialysis, in their body. It has not left their body. So the way that we remove all this fluid and waste products is by implementing some type of vascular access. So we're going to, with the hemodialysis, we're going to pull blood from the body. We're going to run it through an artificial kidney or a dialyzer, and then we're going to it's going to remove all those waste products. Okay, it's going to remove fluid. And there's some things it doesn't remove. We'll talk about that. And then it's going to be returned to the body. Okay. With hemodialysis, we create an access, and we use fairly large bore needles that we are going to then access that we call a fish. Okay. Or there's a graft which is synthetic. You can go to a dialysis center. So there are a number off Cape in the area, so everywhere across the country. When patients travel, they want to make sure they know and have set up where they're going to be receiving dialysis. Often these companies like Fresenius, DaVita's also come, they are national companies, so they can help you set up your dialysis. So the patient's required for optimal function to come 3 times a week for this dialysis to occur. So you can have an in-center hemodialysis patient comes in 3 days a week. It's typically 4 to 5 hours. That doesn't include travel time. Right? It's time on site where they are being dialyzed. So a staff-assisted treatment. There are morning sessions, afternoon sessions, evening sessions, and then there's overnight sessions. So maybe it's for that person that wants their daily life as normal as possible, and they come in overnight for the 5 hours, and they get their dialysis done overnight. Do any of the places that you've gone, do they offer overnight dialysis? You know, they don't. So
They
just
don't really.
treated in.
yeah.
But also too, for Fresenius, they, I asked about this, they also do outside as well.
Okay.
They themselves have like, yeah, health quality of life.
Yeah. So, travel, it'd be nice to be able to travel.
Yeah.
Another option for somebody that wants to travel would be peritoneal dialysis.
So what reasons would there be to one over the other, hemodialysis versus peritoneal?
So it would be the decision between the patient, so, or the, there could be some contraindication where a patient may not be a candidate for peritoneal, then maybe they have scar tissue that happened in previous surgeries, or.
Is it having to do with severity, like?
Typically, it's a patient decision. So for every 1 kilogram of weight that they remove, that represents about a liter of fluid. So you can imagine, fluid.
How much did you say?
So about a liter of fluid or 1,000 ml of fluid. So the most common form of dialysis is hemodialysis. We would access the vasculature, and fistula is created, we're gonna talk about the different types of access in two more slides, but, they use like a cannula, so a very large 4 IV, and they, will access their fistula. It's been created, it's the anastomosis of an artery and a vein, okay? We'll talk about it more on this slide. But you can see that the machine behind the patient, so the arterial line is going to take blood from the body and is going to send it on a pressurized system to the dialyzer. And within the dialyzer, there is a semi-permeable membrane they use. So that you have two compartments. You have the blood, and then you have a semi-permeable membrane, and then you have what we call a dialysate. We'll talk about that as well in a minute. And they're going to be able to regulate, they're monitoring the patient's blood pressure. Pressures can be very, very high. Did you notice a definite change in pressures in your patient from coming in, right? So they've got all this fluid on board. The blood pressure obviously is going to be elevated, and then that pressure is going to hopefully return to normal, but hypotension can be a complication of dialysis as well. So they do monitor pressures of the patient, they monitor pressures of the machine, because that pressure within the machine is really, really important, as it can cause damage to the red blood cells as it's traveling through the dialyzer. So the pressures are too high, that can cause breakdown of the red cells traveling through those hemolysis, right? So that's not good. So there are pressure alarms. I'll hear a lot of different alarms if you were in dialysis situation. So what were the types of alarms that you would?
We have to check. Okay, well, yeah. We have to check, what are they checking every 30 minutes? Blood pressure? Yeah, blood pressure, and then, each individual one has like different parameters.
Yeah.
So it's small. And so
Yeah, so you can imagine, if you're going overnight to do this and trying to sleep, then might not make for good rest. All right, so another method is to have a catheter. So let's say you do have that patient that's come in the ED, they're stage 4, they're in that, they're uremic symptoms, they're acutely ill, and you need to dialyze that patient. Or it could be a patient with snake bite that comes in and they're in renal failure and they need to temporarily go on dialysis. Sometimes we place patients temporarily on dialysis as a treatment to see if the kidneys are going to recover. Okay? So there are situations such as that. So a catheter is placed, like a central line is placed, a little vein in the neck, the chest, and the leg. And this catheter is specifically specified just for dialysis. Okay? So we wouldn't be using it to give other things other than use for dialysis. Because why? That's their lifeline, right? So when somebody has an access, whether it be a fistula or a central line, that is their lifeline. So that's protected at all costs. Okay? So that is the reason why when you have a fistula or graft, we aren't doing vitals. We're not drawing blood. We're not pumping up the blood pressure. We're putting a tourniquet on that arm. We want to protect that access at all costs. Okay? In the ED, I had a patient come in once from out of state, and they were coming in the ED, and they had a dialysis catheter, and they're like, oh, just we can use my catheter to get the labs. I don't need to be stopped. I don't need an IV. Unfortunately, we cannot. We unless it's a dialysis staff, dialysis nurse, they can access it, but we want to protect that at all costs. So really, really important in your assessment, in your physical assessment, your interview with the patient, you're asking if they have, they might be a dialysis patient and you may not be aware of it. So you may not see the fistula in their arm.
Yeah. What causes a fistula for you? So that I called a patient at EIP and he went down for surgery because this was his third time getting a fistula and they just continued to fail. What would cause that?
So it's an artery and a vein. Like fistulas, you can, from repeat cannulation, it can cause weakness in the vessel, it can cause aneurysms. I don't know if you've ever seen an AV fistula where it's very tortuous. Those are aneurysms that can form from weakened areas of the vessel from repeated cannulation. You can get scar tissue, so you can get occlusions or clots there as well. So there's a number of things that can cause that. I was on the ER for yesterday with first year, and we had a patient who was going for dialysis off the floor for hemodialysis, and in the report we heard that the patient had a fistula, but when we went in to assess the patient, we tried to listen for a bruit and feel the thrill right over the fistula, and it's nothing. So come to find out, the patient's fistula was not functioning, and they had a central line in place for dialysis. So you want to always assess your patient, talk to your patient, make sure you examine them fully to know what's working, what's functioning, what's not functioning. A low down on that. All right. So we've got here A is the central line. And it's just like any of your other central catheters, there are specific types of catheters that they're going to use. Something called a Quinton catheter is a common dialysis catheter. So they're going to use that. Or there's this fistula that they create where surgically ahead of time, not in an emergent situation, they go to the OR and they create an anastomosis between an artery and a vein. And then they would cannulate the artery and the vein, and the blood is going to be pumped out of the patient's catheter or the fistula into the bloodline. So it goes into the machine, into a dialyzer. There's a pressure monitor right here, so it makes sure that red blood cells are not being damaged. And then there's heparin that's part of this, right? Because that's going to help keep the blood, so clots don't occur. It's added to prevent clotting. And it goes through this pump, and here's your heparin. And then it gets to the dialyzer, okay? So there's this piece within the machine. It flows into the dialyzer, and that's where the filter occurs. So this has been described to be like putting a bag of tea in a cup, okay? So we're talking about the same stuff we learned about with osmosis and diffusion, right? So some things are going to cross, there's semi-permeable membrane, and some things aren't, right? So it depends on the size of the particles. So fluid's going to cross, or electrolytes are going to cross that semi-permeable membrane. Red blood cells are not going to cross. Protein typically doesn't cross. They're too larger particles. So, and then what happens next is there's either two things that happen. You can have, after it goes through the dialyzer, the blood is cleansed, And then if it goes through, one tube, it's gonna be returned back to the body. If it goes through the other tube, that's all the waste products going out. So literally it goes into your sink. Okay, so you've seen have you seen they use the sink in the patient's room, and one of the hoses off of the dialyzer is all the waste products. So, and that includes like urea and, all those things that are, all that waste product is gonna go, into the sink. But the dialyzed, fluid is gonna return to the patient, okay? All right, so waste products into the sink, and then the type of dialysate is going to be dependent on the patient's needs. They call this, they used to call it an acid bath because it was fairly acidic, but now they have added bicarbonate or buffer to the dialysate liquid. And the reason for that is that the acidic environment would cause the patient just to have nausea and vomiting, and they would just have nausea and vomiting the entire four hours that they're on dialysis. You can imagine how wonderful that was for the patient. So it was actually a nurse that said, hey, they would give bicarbonate after the patient had their treatment, and it would help. If they gave it before, it'd just be dialyzed through. But what they did, they added bicarbonate to the acid bath to make it more basic, right? And that now has helped patients so nausea and vomiting is really not an issue. Did any of your patients have nausea and vomiting?
They could be vomiting, but actually a lot of patients were complaining that after dialysis, they had a lot of nausea. And they were really exhausted. By the time they recovered, it was time to go back to dialysis. It's really horrible. It's really like,
Not a good quality of that.
and a lot of them are on transportation.
What other symptoms did they complain of? So fatigue and not feeling well.
Yeah, what was really cute is a lot of them talked about all the foods they really missed eating, that they couldn't anymore.
Yeah.
Mostly soup. But they, it's funny, it's dependent on per person, because some of them, it wasn't even by age either, like, there was one particular guy that he felt great every single time, like, back then. And then one guy had to get picked up by the vet, he got to the dealer, and he run the feelings, he wasn't sure if he was. But, the thing that they kind of focused on most was their electrolyte,
Yeah.
balance.
So were they monitoring the electrolytes throughout the?
Yeah, and it's all per, the doctor's orders. Some of them, they have like a very strict meal and plan, fasting diet, and you have to add. She got to be okay, and they're not supposed to eat in the day, they're
Correct.
hungry and they're cranky.
So apparently from what I hear, pieces delivered to the dialysis machine, they eat all the time, like during dialysis, so they're not supposed to, because it's an environment that should be very,
Yeah. They like to sneak in and stuff, but it's, I think, you're surrounding people so much, they know these nurses and know. I felt so bad.
were the staff able to spend time talking to the patients, or was it very focused?
Yeah, because they're there for average 4 hours. But the way
it's kinda like
they
the
schedule is really cool, it's like they'll have it a little bit
Staggered.
yeah, so they won't have all get off at the same time, they'll have a little bit of time to talk to them. And then it's like they have this rest period of time, and then it's go, it's more for it's small constraints.
No, that's great. If anybody's interested in working with patients with chronic kidney disease in dialysis centers, they do hire, new grads. You do have to, really have a really strong understanding of,
I think they send you to training, though. They have tracks there that they definitely, I'm not sure. They must be nurses. But it is good if you like want to consider, like, they're closed on Sundays, you'll never have to work Sundays. It is long hours, they're very flexible with their schedule, if you have kids. From what I've heard, they didn't exactly like say their pay, but I think they did. Is it 30? Oh, it is?
But you can get raised, if you do some things that they have, you can get raised like 2 times a week.
Oh,
So
okay.
it goes up pretty fast, as long as you're getting your food.
one of our graduates, Donna Steiner, who actually used to come and do this lecture, she graduated in 2018, but for quite a few years, she came in and did this lecture. Actually, a lot of these slides are hers. But she was the, like, ended up, you know, she started, in med surge on the unit, then went into dialysis, just DaVita, and she did it for science, and then she became the regional director, for all of New England, and, she moved her way up. She educated all the new nurses. She was an awesome, educator. And now she's a real she's a social worker. She originally was a social worker. All right, maybe she's doing combination. All right. So that acid bath, the dialysate, is determined by your electrolytes. So if you have, going in with, obviously they probably all have elevated potassium, right? They would have a low potassium bath. So through osmosis, infusion, those potassium particles, if there's low potassium on the other side, through that membrane, that's going to diffuse across the membrane and lower that potassium to be dumped with the hose going out, and then so then now that patient has a lower serum potassium. So we do see massive fluid shifts, and especially for these patients receiving dialysis for the first time, right? So they have massive amount of fluid spacing. They see really high pressures, 200 over 100, and they can go from really, really high to really, really low. So that's why they do hit over 4 to 5 hours very slowly. They monitor the patient. These patients typically, their first dialysis is going to be in an inpatient unit. So they can monitor them and watch those massive fluid shifts and making sure that the patient's stable. But it's not uncommon to go from like 200 over 100 to 60 over 30 with your blood pressure during this first dialysis. And we're always watching for arrhythmias as well, right? The shifts in the serum. So it's a constant process, and it just goes continuously over that time. The fluid goes back into the vasculature. It's possible to have a sensitivity allergic reaction to that synthetic membrane that acts as a semi-permeable membrane. It's considered biocompatible, but it is possible to have an allergic reaction to it.
What would they do then? Just Benadryl or?
So I don't know if there's any other alternate, like somebody's got a reaction. I don't know if they retreat them possibly, or if they have other materials in different machines. That's a good question. Or would they be a candidate then for hemodialysis or peritoneal dialysis?
When they usually that she was embarrassing, started on she was okay, but she just turned red.
Turn red.
And then they came and they stuck it there.
probably depends on the severity too, if they're having, going into anaphylaxis.
Right. Other complaints could be, and then I've definitely seen this with patients and inpatient, they complain of muscle cramping during the procedure, and that could be really uncomfortable. If you are a nurse working in acute care, and, you know, your patient's going for dialysis, often they will hold all of their medications, right? Because all those medications you give, they go into dialysis, they're all gonna go across the membrane, and they're not gonna be available to the patient, to be absorbed. So, often the medication will be held till they return from dialysis. And if you have, you know, say you have a really hypertensive patient, the dialysis is gonna treat that, right? Yes.
I've had two dialysis patients before, and usually they tell us to give them their medication.
They do give them on your
Especially their heart medications.
Okay. All right. So, and that would be specific, to the patient. You would wanna clarify that. Okay. So here we have the patient's what like a central venous catheter would look like, subclavian. You've got your arterial and your venous port. These are often temporary until you can get something more permanent, but they could be permanent. Maybe they're not expecting a long lifespan for the patient, or their vasculature is not going to support an AV fistula or graft. So this is the next best thing. These obviously can easily get infected, and it's going to end with subclavian vein right above the right atrium. Okay, so it's our central line. So all the same care for that central line, but this is only accessed by your dialysis staff. Yeah, this is not placed at the bedside, it's placed in the OR under really sterile technique. The second access is the AV fistula, where you join the artery and the vein. And it's the most desirable type of access and the most common type of access. It has the fewest complications, infections. Really anastomose the artery and the vein, and then they cannulate it with a large 14 to 17 gauge needle. So it's a very large, how do the patients tolerate the cannulation? Do they numb it?
They have their own little like,
Spray?
spray.
Like a light?
Yeah, but it's,
So you can see how it can, over time, damage the vessels. Did they talk about how they rotate where they cannulate it?
yeah, it was hard to watch.
And also, like, when you remove the needles, you will just have another powder that you put on, because you
He had a powder that he would put on it?
to stop the blood. But you
Because he
just
would
bleed,
lose.
yeah.
When a fistula is surgically created, you can't use it right away for dialysis, so it's a good 6 to 8 weeks before you can then use this. So it's got to heal and mature a bit. All right.
So do they use the catheter in the meantime?
They would, so that would be, they'd have both, and they'd have that catheter in place while this is maturing. And they have to really be told to really protect that extremity. All right, then we have, if they aren't able to place an AV fistula, an AV graft would be the next best thing. So they use a graft, synthetic graft. There's a question on the exam about these grafts. So they use the graft to tie the vessel together. So maybe the patient doesn't have the best vasculature, so they actually, this is going to be more durable. And the patient is cannulated on a graft versus on So they're still going through the skin, obviously, but, they're still, it's cannulated only through the graft. So you've got to obviously be able to tell where the graft is, and if you've seen somebody with a graft, you're gonna notice it's much firmer and it protrudes. You can see. So those who have far vasculature. One thing I want to say also about the central venous catheter, you can use a tunneled catheter. That, if you remember when you learned in advanced IV this last semester about tunneled catheters, they're made of Dacron. Okay, they have a antimicrobial cup, right? So this, and the purpose of that cup is to stabilize the catheter and hold it in place. And then it's also, the purpose of that is to prevent microorganisms from traveling from the skin in. So if they reach the cup, they're going to get stuck there, and they're not going to travel and get into the bloodstream and cause sepsis, right? So make sure you remember those things, okay? We are going to listen for function. We check CSM distal. We're going to feel the area for a frill, and we're going to listen for a bruise. So we'll hear like a whooshing sound. It will definitely have a distinct sound with the anastomosis with the artery and the vein. We kind of discussed this already. We have individualized electrolyte concentration based on the patient's needs. So if they've got very, very high potassium, they have a certain concentration of potassium in the dialysate to allow that pull of the potassium across that membrane to bring serum potassium down. The bicarbonate is a buffer, helping base balance. It's going to help with nausea and vomiting. They use purified water as part of the dialysis. So the dialysate and the blood never mix together unless there is a break in the dialyzer membrane or blood leak. Dialysate is not sterile. These are highly digital machines that measure pressures and did they say how long their training process was?
I think she said they were at the fair. I thought they said 6 weeks. They did a part. I think they did the first 3 weeks in Rhode Island, and then the rest here.
So these are some of the complications we talked about: muscle cramps, hypotension, nausea, vomiting, headache, itching, chest pain, back pain, fever, and chills. So these are all the things that you are monitoring for. Okay, let's say your patient chooses peritoneal dialysis. They want to not have to go to a dialysis center 3 times a week. They want to be able to do it in the privacy of their own home. Okay? So peritoneal dialysis is the same idea, except it uses the peritoneal membrane in the abdomen as the semi-permeable membrane to filter the blood. catheter, a peritoneal catheter is implanted into the abdomen surgically in the OR. And then, they use the dialysate, so that requires quite a bit of storage in your home. So if you're traveling on a country in an RV, it is doable, but you have to have place for all of your dialysate bags, right? And they do these what are called exchanges. They're exchanging the dialysate. So they would attach the dialysate bag to the catheter, and they open the clamp, and that's going to infuse slowly into the abdomen. It's going to stay in that peritoneal cavity for, how long is it? Half hour to 1 hour, okay? And then they're going to lower the bag, clamp it, and then through osmosis and diffusion, the fluid and the waste products are going to drain into the bag.
So the patient just does this on their own at home?
They do this on their own at home. There's a couple different methods. You can do it overnight, even there's continuous, I don't know, that's a slide coming up, continuous ambulatory peritoneal dialysis, and there's a cyclic dialysis that you can do. So there's what we call a dwell time, which is about 30 minutes to an hour. So you instill the dialysate, it sits in the peritoneum. The waste products cross that semi-permeable membrane, the peritoneal membrane, into the peritoneal space. And then the bag is lowered, it's unclamped, and that fluid and waste are going to be drained from the peritoneal cavity.
Ideally, will you be getting more fluid and waste than what you're putting in, or would it be the same amount?
It's about the same amount. So that's a really good question and point. So one of the things, what do you think they use best? And we've talked about this with like heart failure and everything. What's the best method for assessing fluid loss?
Daily weight.
Your daily weight. So they have what's called a dry weight, and that's the patient's weight that they're going to use to compare, and then they're going to try to get the patient's weight back to. So their weight after they've had an exchange and they're in their best fluid balance state would be the dry weight. So you're gonna weigh yourself after each exchange and see where you're at.
Sorry, say the dry weight one more time. It's your weight at your most ideal.
Right, so the weight you want to get to, that's
Okay.
your weight. They're also going to be in tune with symptoms they're having and their blood pressure reporting. So those are also indicative of fluid balance. If they're drinking a big coffee while they're doing the exchange, they have to account for that.
So this one doesn't have like the acid bath and all that.
So the dialysate is your bath.
So how do they know if they're doing it, like what the electrolytes are and?
So most likely it's going to stay pretty steady.
Okay.
This dialysis bath is going to be what's appropriate for the patient.
Okay. Can it change though if they have?
They can, and maybe
I had a patient that had like two different
orders, recipes.
Yeah.
Like based on.
So they, for this, they would
Electrolytes
do
if the
4
bath needs to be
exchanges a
lowered.
day, 7 days a week. So now we're going from dealing with this 3 days a week, up to 4 to 5 hours every day, 4 exchanges a day, okay? So, and it takes about 30 to 40 minutes per exchange.
There's a 4 per day out there. Right there.
So there is, that's called a continuous ambulatory peritoneal dialysis. And then there's a cyclic. It's similar to CAPD, except they use a machine that automatically fills and drains the dialysis from the abdomen. So this is what's done overnight, over a 10 to 12 hour period. The exchange is completed nightly. So that seems like a pretty good option.
Yeah, I mentioned that whole, because she was getting this CAPD, obviously hospital, but then she said she used to go in and get home, so now she has those.
And because you have this catheter going into your peritoneum, to your abdominal wall, infection risk is obviously high, right? Because you have something invasive. And you need to make sure that all the teaching is done. And that they have everything they need to do it appropriately. So the pros are that it can be done alone. There's flexibility in where and when they can do it. There's fewer fluid and dietary restrictions because it's actually more ideal for the body than doing hemodialysis where you get an accumulation over several days. You don't get to that point where you accumulate that because you're doing it more frequently. So the cons are that you are doing it more frequently. It can disrupt your daily schedule. There is potential for peritonitis, abdominal infections. You have to have adequate space in your home to store the supplies. And for all of these, it's not a cure. So a cure would be a kidney transplant, but obviously with proper treatment. So similar to any person that has any type of organ transplant. The greatest impediment to those with a kidney transplant that are eligible is the lack of sufficient donor organs. So we don't need two kidneys to live, and oftentimes like a family member or somebody that's a match could donate one of their kidneys to the patient. Right? So that patient then has a functioning kidney, and now the donor has a functioning kidney. So you do have to protect that kidney at all costs because that's now your last kidney. When somebody has a transplanted kidney, once the transplant's done, oftentimes that kidney works immediately. And you'll see a huge diuresis that occurs. It's a very positive thing. Or it could take several days for that kidney to kick in and start working. So that would be something that you'd be watching for. And just like with any other transplanted organ, we're looking for signs of rejection. We're making sure that the patient is aware of the risks and benefits to immunosuppression, because now to decrease that risk of rejection, these patients now are going to have to go on lifelong immunosuppression. Right? So very important that they receive these. But now they do have a suppressed immune system. They're at increased risk for things like lymphomas and cancers and infection, and maybe from the common cold to cancer. If you have a donor relative, that definitely speeds up the process. So we've talked about these. And then there are those patients who do choose palliative care, and they choose not to have treatment. And this would be, end of life. So symptom treatment, comfort measures for this patient, should they choose not to have any type of reimbursement. Are there any questions? I'm going to just go to the AHA slides real quickly.
Are you gonna post these as well?
These will be posted. So you should be able to Okay, we're gonna go ahead and start. Which of these would you expect to pass through the dialysis? So there are certain things that are too large to go through the dialysis. Good. So our red blood cells don't, they're too large, okay? So they're gonna stay, within the tubing, so that's good. That's all gonna be returned to the patient. Electrolytes do pass through the dialysate, and our waste product, which is the accumulation of urea and nitrogen, in the blood is going to pass through. What is the purpose of the peritoneal dialysis catheter cup? So these cups are not Teflon, they're Dacron. So these antimicrobial cups, they're going to stabilize the catheter. So I talked about this with the central, but also the peritoneal catheter. They're going to prevent microorganisms from traveling from the skin and coming down the catheter and infecting the peritoneum, or if it's a central line, infecting the bloodstream. There's no thrill and bruit, so your AV fistula is going to have a thrill and a bruit. The cup also, it stabilizes the catheter, that's one of its functions. So it's Dacron, it stabilizes, and it prevents microorganisms. So do remember that. So these patients with renal failure, what kind of dietary changes would be appropriate based on what you know about renal failure? Okay. So there are restrictions on fluid, right, for patients with renal failure. So it can be anywhere from, depending on the patient, but typically 1 to 2 liters of fluid. Typically, potassium is being retained, so they have high potassium, so you're not going to encourage a high potassium diet. You want a low potassium diet. And you do want to limit sodium. With sodium comes water, you're going to have more fluid retention, right? And then there are restrictions on protein as well.
Can you just talk about that protein a little bit? I was unsure of that. Is it so you don't put more work on?
So protein is it's a larger it just adds the filter it just doesn't filter well.
Is that
It's larger.
specific to dialysis or specific to kidney failure?
So that would be typically for both. So you should limit their protein. the possibilities for that would be a frill and brewery over the AV fistula. The peritoneal dialysis has a semi-permeable membrane in the abdomen. The graft is an artificial tube bridging the artery and the vein. And then that central venous catheter has the highest risk of infection of all of the different types, comparing all the different ones. And that catheter can be subclavian, it can be femoral, different areas depending on access.
Do they generally start everybody on dialysis with that catheter, given that the other forms need to heal, or do they wait until it's healed, or what? Like, they can always right?
Yeah, you know, if they can plan ahead, they could, I would think most often they would be, because it's gonna take 6 to 8 weeks for like a fistula to mature. So most often, you know, unless they're planned way in advance, they typically will have a simple catheter first. All right, if you have any questions, you can email me or come by my office. All right.